Hello, my name is Aarya Ramprasad, and I will be presenting our team's poster on social determinants for explaining disparities in COVID-19 rates, a population analysis from 10 large metropolitan areas. The COVID-19 pandemic has affected millions around the world, with many people being left vulnerable due to their socioeconomic status, which is an important determinant of health. Disparities in COVID-19 disease risk, mortality, and morbidity in association with race, ethnicity, and socioeconomic barriers have been well described and documented in literature. We aim to see how social determinants like racial makeup, median income, and healthcare providers would be associated to COVID-19 disparities across the U.S. In terms of our methods, we identified top 10 populated cities in the U.S., which are stated here, and the only one that we did not include in our study was Los Angeles, which was replaced by Austin, Texas, the 11th most populated city, due to Los Angeles not having enough COVID-19 statistics. Code cases were taken from zip codes of the top populated cities from the health departments. Racial demographic information, median income, and primary care providers, which included internal medicine, family medicine, and pediatrics, were taken from zip data maps, income by zip code, and health grades respectively. These zip codes were assigned into a racially advantaged, which was made of white or Asian, and racially disadvantaged, which was made of Hispanic/Latino or African American, as well as financially disadvantaged, which was a median income of less than $69,000, and finally advantaged, which was above $69,000. Tests that we included were the Spearman's rank correlation, the Mann-Whitney U test, and multivariate Poisson models that were all performed on SAS. Our results showed us that racially disadvantaged neighborhoods, on average, had 1,653 more cases per 100,000 people than the advantaged neighborhoods. Low-income neighborhoods, on average, had 1,683 more COVID cases. There were 183.9 more providers available in higher income zip codes and 108 more providers available in racially advantaged zip codes. Figure 1 shows a comparison between increasing numbers of available providers and cases that were conducted, showing that more providers led to a smaller incidence of COVID. So as our quartile numbers went up, the number of providers went up. For example, our quartile 4 was our reference, which meant the most number of providers. So as you can see in the table below, as the quartiles go up, the COVID incidence ratio goes down. So higher rates of providers, such as quartile 3 or 4, led to a smaller incidence rate of COVID. So one general factor is that in the idea of discrimination, it ends up leading to chronic and toxic stress that shapes social and economic factors, and this could be leading to higher case rates. The systems that control these factors are government. These systems include housing, education, criminal justice, and healthcare. Racial discrimination, which is something that has been seen to lead to a lower quality of care. A lot of minority groups end up having worse care than non-minorities, and these minority groups experience a lot more morbidity and mortality from various diseases. Lower median income relates to a lack of educational opportunity, and that leads to a smaller job pool, which led to a lot less flexibility and paid leave in case of illness like contracting COVID. Finally, minority groups are also a lot less likely to have insurance coverage from a private employer, which goes back to job opportunities because many of their jobs do not offer it. And this leads to a lot of people using a public health insurance, which may not have as much coverage. So in conclusion, we saw that our median income, racial demographics, and healthcare provider availability played a huge factor in COVID case rates. These same results are also starting to be seen in vaccine distribution. The data that was collected for us was in 17 states at the time, and the trends showed that shares of vaccinations among Black and Hispanic people were a lot lower in terms of the rates compared to those shared of the total population. So in Mississippi, Black people account for 15% of the vaccinations, but 38% of the cases and 42% of deaths. So we hope that reducing these disparities would require a lot more preventative health measures and coordination with federal agencies to supply funding to the communities that need our help the most. Thank you so much for listening, and have an amazing day.